right, so we'll go ahead and get started. So welcome everybody to our fall virtual meeting. I'm going to dive right in because we have lots to get through as usual. Here are the ways that you can receive CME or CE credit. If you've already registered for the meeting, you already have been emailed the CME handout with the phone number and the link, and we'll send it out again after this meeting. We're also adding it to chat, so do not worry if you forget to text this number. And then if you don't text a number, it's just going to be a slight delay before the evaluation is added. And then please complete it no later than November 20th. Listed here are the CME and CE credits for physicians, nurses, pharmacists, and dietitians. Here are our disclosures. And so you asked and we agreed. So we're all here tonight virtually based on feedback from you. And so we're really excited to deliver this virtual experience. We hope you find it helpful after a long day in clinic. We still want to make sure this evening is interactive as possible. So with that in mind, we have some engagement guidelines here so that we can continue to offer this meeting virtually. So first, let's turn those cameras on. I want to see all of your faces, so the camera should be on you. You need to be present for 90% of the meeting. We are going to have a short break at the halfway point, but if you need to step away for just a couple of minutes, that is perfectly fine. You must participate in all of our polling questions this evening. And then finally, at the end, we're going to ask that you fill out an evaluation. So that must be completed again to receive credit. If you have any technical difficulties or concerns, please message us in chat. We all have MCT2D after our names, or hopefully we will soon. And then with that, I'm gonna move on. So here is a little glimpse into our agenda for the evening. Again, that evaluation is critical at the end. Tonight, we have several speakers, including one of our patient advisors, and Caitlin McEvely Rosenbach from the National Kidney Foundation of Michigan. So this is, again, one of the benefits of being able to host this meeting virtually. So without any further delay, I'm going to turn it over first to Noah, who's going to give us updates on our coverage checker.
Thanks so much, Heidi. My name is Noah Kim, and I am the informatics design lead for MCT2D. When I last talked to many of you, it was at our collaborative wide meeting where we launched our digital version of our coverage guide called Coverage Checker. In the first release, we offered the ability to reference CGM coverage criteria and to search by many of the major Michigan health plans. And today we're excited to be able to share that we have the option to search medication, so search GLP-1s and SGLT2s. You will find that the interface looks pretty much the same, but maybe with some improvements to streamline and get you that really need to know information, such as which products are preferred versus non-preferred, if there's an ability to bypass the PA, and if so, how to do so, what the PA criteria is, and then those standard features like sharing the search with a member of your team and seeing related MCT2D resources. So we're really proud that we can share this tool with you and hope that you'll be able to use it and integrate it with your practice and share it with others in your practice. And also to keep us in the know. If you find that you've heard about a plan change or you see something that could be improved, please do use the embedded form within the page or send us a message. Just we really do take your input seriously and try to implement and prioritize things that members tell us. So we're excited that we are able to launch this in October and are looking forward to future enhancements in the spring, including a really exciting project that is underway that my colleague Julian is going to talk about next. So thank you.
Thank you, Noah. Okay, so I am happy to announce that we will be launching a MCT2D mobile app coming spring 2025. And you might ask, why are we doing a mobile app? It's because our members were requesting things like easier access to our tools and resources. We actually hosted 2 focus groups last winter to make sure our members were part of the design process. We want to make sure that when we create something new, that our members are really a part of the foundation of the idea and the design. And we heard requests like access to a coverage checker through their phone. So the MCT2D app will feature things like their resource library, our current resource library, and it will have resources specifically designed to be viewed on your mobile device. Upcoming events will be accessible really easily from the home page or from the home screen. MCT2D news, and of course a light version of our coverage checker. So the resource library, one of the most exciting things that I get to announce about the resource library is that we are making it accessible to you to the point where you can view, save, and share the resources right from your mobile device. So you'll be able to send those to patients, to colleagues, just by adding their phone number or their email address. And you won't have to worry about your number being shared or your email being shared. It will just go straight, it will go straight to your colleague or patient, and it will show a MCT2D email or phone number. So Coverage Checker Lite, from your mobile device, you'll be able to check the eligibility requirements for CGM and medications. You'll be able to review preferred and non-preferred prescribing details, including prior authorization. And you'll also be able to share the results from your searches with staff from your phone as well. So, same process, you would just enter their phone number or their email address, and they will receive the same search results that you found, and it won't actually share your phone number. Okay, I think that's weird. Anyway, and with that, I'd like to pass it on to Jake to discuss the dashboard updates. Thank you all.
All right. Good evening, everybody. I'm going to advance our screen here. All right, so we have some exciting news as it pertains to the patient data dashboards. And so just kind of sent everybody as to what we're talking about when I say patient data dashboard. To remind everybody, MCT2D has two different systems that sometimes are referred to as dashboards. We have our admin portal, which is where you can view all of your information about your participation in MCT2D, the requirements, VBR, things such as that. What we're going to be talking about tonight is dashboard, the patient data dashboard, which is where you're able to view actual patient information pertaining to type 2 diabetes, quality of care, trends for your practice and your physician organization, and how it compares to other practices and POs participating within MCT2D and the collaborative as a whole. So the patient data dashboard is something that we are always iterating upon. And we have a couple of different ways to get into the patient data dashboard. So on the MCT2D website, in the top right-hand corner, you'll notice a button that says patient data dashboard. This is a button that'll take you directly to the outside link that will go to that patient data dashboard. You're able to access it through here as well as through the Michigan Data Collaborative site, but this will be the most straightforward way. So when you get to after you click that button and get to the landing page for it, you'll notice two different buttons to log into. The first is what we had previously, what you probably are familiar with. We're calling that now the legacy patient data dashboard. Our new feature, the patient data dashboard 2.0, is what you'll see here. This is what's new, and this is where you'll notice a few new features, and we'll talk about those in just a minute. There's a QR code on your screen here that'll take you to a page on our website that will have information on getting started with Dashboard 2.0. It'll walk you through how to utilize these new features and functions, what's different, and how they could be beneficial to you in your practice. After you click Dashboard 2.0, you'll be taken to our landing page here. And that landing page will also have a second link to be able to link back to the legacy patient data dashboard. So we have tried to integrate them. Eventually, that legacy patient data dashboard will go away and we'll have it all integrated into a singular dashboard. We know this is a little confusing. It is a hybrid model for the time being, but it is a temporary thing. But as of right now, when you get to the landing page on the Dashboard 2.0, you'll notice a bunch of different options to click on. The current ones that are available are summary measures and the user guide. The other pages are coming soon. You'll notice the coming soon flags on those after you get in there. That is what we're currently working on. So we'll take a look at the summary measures page, which is, again, what we have available as of right now. So on this landing page here, you'll notice that we no longer have an attestation that you have to click to be able to get access to the page. So that removes an extra click and streamlines the experience a little bit. We have an updated data banner that will continue to be updated every time the data is refreshed and help you know where exactly the data is coming from and what date it goes through. Underneath, you'll have some items here for FAQs. It'll walk you through some of the information about the data sources and the different features and functions. So here's the first kind of glance, and we'll take a look at this in a couple of different ways at this summary measures page. So this is going to look a little bit different, or really completely different than what you'll have noticed in the old summary measures build comparisons report of the legacy dashboard. So we are continuing to build out additional features in ways that this summary measures page will show different comparisons. However, we wanted to start with the big ticket items. And so you'll notice at the top of this page that you'll have the A1C criteria associated with the performance measure at the top there. And then below you'll have items such as the screening measures, so retinal exams, CKD exam diagnoses, those kinds of things. And then underneath that, you'll have prescribing measures. So that'll look at medication prescribing, such as SGLT2s and GLP-1 receptor agonists. You'll notice here that we have an expand button. After you click the expand button, you'll have additional ways to view each of those high-level summaries. So if you're interested in this particular measure on the main summary page, do definitely click the expand button so that you can look at it in a little bit more detail. That'll include at the practice level rather than just the PO level if you're a PO level user and have access to all of the practice data within the PO. And you'll notice here that we are currently working on an additional view of the top two measures, the A1C performance measure, so that we can narrow it down to the current VBR performance population, which is that baseline population that was sent out to your POs from MCT2D back in the beginning of September. So Noah put in a chat here, the getting started page. That'll link you out here to the Dashboard 2.0 tutorials. This link is in the chat again, and you're able to get to this and go through some simulated tutorials for it so you can kind of get an idea as to what to expect before even getting into the dashboard and trying to navigate Dashboard 2.0. So do check that out. And then the next item that'll be coming here, and we're currently in progress with this, are some pre-populated reports. This will take some of the onus away from having to build reports on your own. The two reports that we're starting with right now are the data completeness report, which will give you an idea as to how many patients we have a particular lab value for out of your total patient population. And then more importantly, a trends report. And so you'll be able to look at practice or PO level performance across the various clinical measures. So A1C over time, blood pressure control over time, urinal albumin creatinine ratio, for example, over time, trending in a run chart format. And then that again will be able to be broken down at the practice level. And then when it's include target rates. But again, not everything is a performance measure as of right now, as you know, but that is something that we'll be able to integrate when there are target rates. So there's a question in the chat. Where in the chat is education to help? So Noah put a link. Noah said, here is the patient data dashboard 2.0 getting started page. And so in their chat, you should see that. And they just linked it again. All right, so on the docket, again, for future enhancements here, again, this is not quite available yet, but it will be, is a revised patient profile page. So this is, again, available through the legacy dashboard. It's just not quite as pretty as this current one. We're working on integrating some user-centered design here. The design team has done a lot of feedback sessions with you all to understand the different ways that we can improve upon it. So this will be organized very slightly differently. So there we go. Across the top here, you'll see the insurance coverage as well as the primary care and specialist provider attribution. You'll also see that the trends are a little bit more centered at the page and show the different biometrics over time. And then on the right-hand side, you'll notice that the biomarkers and labs are called out in a little bit more clear fashion. On the bottom, you'll have an indicator of which medications, including CGMs as a device, the patient is currently using and which ones are no longer being used by that patient, but have a claim in the past over 6 months ago. Screen's lagging. There we go. And then next, again, this is again in the works and not quite available yet, but the next stage after the patient profile will be the patient list. And this will include a revised experience as far as filtering is concerned. So the way that we're envisioning this is that you'll be able to build nesting filters so that there isn't a ton of filters all listed at the same time. You're able to pick and choose the different clinical categories of interest that you want to filter your patient list upon, and then apply those filters to sort those patients to the ones that you're looking at. That'll be, again, something that is created in further iterations of the Dashboard 2.0 project. And then this is care list. This is similar to how we're envisioning pre-populated reports, but reports will focus more at the practice and PO level, whereas a care list will include specific lists of patients that meet criteria of particular interest to MCT2D. For example, in partnership with all of our clinician leadership, we may develop a list of patients who could theoretically be a good candidate for an SGLT2 inhibitor. For example, if they have chronic kidney disease, if they have uncontrolled A1C, are gaining weight, for example, or have, again, never seen or been on an SGLT2 inhibitor, that may be a care list for you to kind of go and say, hey, here's 15 patients that I could take a closer look at. This isn't a list that's saying you need to get these patients on this drug. It's meant to just provide a little bit of extra info for you as the provider and remove some of the burden of identifying those patients. All right. And then finally, we're also going to be incorporating social determinants of health data. This is something that is currently on the docket with MDC for 2025. We are working on getting that data source integrated, and we'll be able to incorporate, we're not totally sure what it's going to look like in entirety yet, but we are hoping to get screening data focusing on different SQH metrics. So food insecurity, transportation, clinical appointments, that sort of thing. And we'll hope to incorporate it both at the patient level as well as at the practice and PO level, showing, again, trends and change over time as associated with your practices and patients. All right, with that, I'm going to turn it over to Rena to talk us through some clinical updates on low carbohydrate eating patterns.
Thanks, Jake. Hi, everybody. My name is Rena, and I'm here to tell you a little bit about some low carb related updates with you all. All right, let's see.
It should go forward. I think there's a little bit of a lag.
Yeah, slight lag. Let me see if it will work now.
If not, I can advance, Rena.
Yeah, Heidi, I may need your help on this one today.
Yeah,
Thank you.
fine.
Thanks so much. All right, everyone. So we firstly wanted to share with you this article that was recently published in the New England Journal of Medicine. It's a scoping review of the widely recognized and scientifically researched dietary patterns. So one of the dietary patterns that was reviewed in this article was carbohydrate restricted eating patterns. And it provides a summary or review of its applications in various disease states, effects on weight loss, type 2 diabetes, as well as future areas of interest within research. And so we wanted to share this with you because as a helpful resource and a reference tool about summarizing what is currently known about these various dietary patterns. And it could be a helpful resource or guide to use to guide patient conversations in practice. All right. And next, we also wanted to share with you a little bit about a program to better understand your potential interest in us developing something like this in the future, similar for MCT2D. So this program is called the Low Carb Journey. It's a self-guided 16-week program that teaches patients how to follow a very low carbohydrate meal plan. So that's going to be defined as less than 50 grams of carbs a day. This program is currently available through in the Michigan Medicine Health System in limited clinics, but we're hoping to first pilot it and gather some preliminary feedback and expand more broadly to other sites that are interested in using this program. So a little bit about the Low Carb Journey, or LCJ. The main part of this program are these 20 educational video modules, and they're based on current evidence-based clinical guidelines. And they also include weekly self-reported assessments of weight and carbohydrate intake. The program will also include some additional supplemental resources such as recipes, shopping lists, meal plans to help guide the patients through making these lifestyle changes. So if we take a look at the next slide, we'll have a quick overview of what the 16 weeks of the program entails. And as you can see, week 1 is the introduction, and the participant will go through each week, learn a different theme. It will go through really the basics of of incorporating a very low carbohydrate lifestyle. So ideas for lunch, breakfast, dinner, how to navigate family meals. If we go over to the next slide as well, which is a continuation, we'll see how to navigate social gatherings and travel, low carb fast food options, how to overcome barriers, and many more. So this is a quick overview of what the program entails. We'll now take a quick poll to see what everybody's interest is from the audience to develop a program similar to this in the future for our sites here. Oh, it looks like there's a question in the chat. How long is each module? Great question. So the video modules are generally between 3 to 5 minutes long. So they're meant to be short, digestible videos that patients can watch, and hopefully not take too much time out of their day to be involved, to be engaged in this program. Is there another question? Oh, so Riley, let me see. I think the poll should still be open.
Oh, I apologize. I closed it. We left it open for like 40-ish seconds until the answer started slowing down, and there was about 5 or 6 seconds between answers, but we can leave it open for longer for the next one to make sure everyone has time to respond.
Thanks, Jackie. All right, should I share the results or see if I can?
Here, I can share them. I had them up for a little bit, but let me go ahead and share them again.
Great. It looks like there's an overwhelming majority of folks on the call today who would be interested in something like this. So thank you all for the responses, and we will definitely take this back to our team and we'll discuss next steps. So thank you all so much. I will now pass it back to Heidi for the next section.
Thank you, Rena. All right. I did forget to mention earlier, especially when I'm going to be flying through a lot of stuff as usual in terms of CGM updates and medication updates. Please put your questions in chat. Our team will do their best to answer. And then once I'm done with my section, I will review all the questions and add my thoughts as well. So just want to keep things rolling tonight. So now we're going to transition to our second pillar. And there's much news in the world of CGMs to share. But first, a quick recap. I know you're all aware of the big win we had back in June with our MCT2D patients with commercial Blue Cross Blue Shield and BCN gaining CGM coverage and being exempt from the once daily insulin requirement. As a reminder, though, this exemption does not apply to patients with Blue Cross Blue Shield of Michigan Medicare Advantage. Related, the prior authorization process has also been streamlined since June. So as of September 1st, they are no longer required at the pharmacy, and then prior auths at DME are auto-approved. It was brought to our attention at our first regional meeting that some claims at DME were not always being approved for patients that fit our criteria, so are being seen by an MCT2D provider, have type 2 diabetes, and have one of these plans. And it also happened to me last week. And so upon seeing this, I reached out to Blue Cross Blue Shield to get some clarification because I was of the understanding that I myself is a provider, PCP was a provider for my patient, and same for some of these examples that were given to us. And my message that I want to get across is just to be persistent with DME. I had to go back and forth 3 times, but my patient is getting their supplies now. The other big thing I do want to let you know is I also reached out to Blue Cross Blue Shield to share this problem with them, and they are being very gracious and reaching out again to all the DMEs to review our MCT2D policy and ensure that DMEs are not putting their procedures, which is what happened in the case of my patient, before our agreed upon criteria for our patients. So, keep us posted, but I'm really hoping because of this, you should start seeing way less hassle for patients that meet this criteria. The biggest thing to remember is Blue Cross Blue Shield of Michigan. So out-of-state Blue Cross plans are not part of this gold carding. So now switching to something that does impact our Blue Cross Blue Shield BCN Medicare Advantage members, please note the exception on the left-hand side in blue. You might have heard from your patients after receiving a letter like the one here that as of October 1st, Advantage members must get their CGM supplies from a network pharmacy or mail order, specifically Optum Home Delivery versus DME. And so while this is fantastic and easier for all of us, there is, however, been a small hiccup. So nowhere in the letter that the patients received or the electronic newsletter that we received does it mention what payer should be billed at the pharmacy. However, it does mention in the letter that supplies will be billed under medical benefits and not pharmacy benefits. So one might logically think that a patient would go to the pharmacy and present their Blue Cross Blue Shield or BCN card at the pharmacy. So patients can show their card because this is partially helpful, but the important key that's missing and not always being communicated to pharmacies is the payer that they should be billing. And so it's Optum Rx covered under the Part B portion of that. Pharmacies are getting constant messages about this. I am sharing it with you just so that perhaps you can copy or print this slide out for your staff that's triaging phone calls. And if you have a patient who complains of previously getting CGM supplies at DME but has to do it at pharmacy, but pharmacy's saying no, this is some information that you're going to want to reflect back on. So speaking of more incomplete information, in August, Abbott released the Libre 3 Plus. You might not have heard about this because the major enhancement is pump integration. And so while this doesn't impact a lot of us in primary care, this is essentially a Libre 3 sensor. So it uses the same reader, it uses the same app. There's a couple of minor changes that I do want to point out. So first, it is 1 day longer, so it lasts 15 days. It is cleared down to the age of 2 versus 4 that the Libre 3 is cleared down to. And this one could impact your patients. The Libre 3 Plus has an increased threshold for safe use of vitamin C. So it's up to 1 gram a day of ascorbic acid. So keep in mind sensors, Libre 2, Libre 3, those, if patients are taking any more than 500 milligrams of vitamin C, it can lead to falsely elevated glucose, which is dose dependent. So finally, the biggest thing that I hope you walk away with, because I've been seeing this now almost on a daily basis and getting messages from my colleagues, is the Libre 3 Plus is not a replacement for Libre 3. However, there's been a lot of misinformation. Pharmacies are unfortunately perhaps leading to some of this misinformation. I've alerted Abbott that they should probably do a better job of educating pharmacists out there in the community. So this could be a result of there's some periodic shortages that some of the chains are seeing with the Libre 3. So here's what you need to know. Patients can switch right over to a Libre 3 Plus, but it does require a new prescription. So if a patient calls and says, pharmacy saying they can't get it, I would, if they say can't get it because it's been discontinued, provide education that it's not discontinued. But in the meantime, you'll go ahead and prescribe them the Libre 3 Plus. So before we move on to some more updates, I'm curious, how many of you have had your patients ask about the over-the-counter CGMs?
I'm seeing poll slow down. Just want to make sure everybody's had a chance before we close it.
Thanks, Jake.
All right, I'm going to go ahead and close it. If you haven't had a chance, please speak now. The
All
results
right.
should be showing, Heidi.
Okay, all right. I couldn't tell from my perspective, but interesting. So a little bit more 50-50 than we've seen at prior meetings. So, well, I hope that as we move forward, this information that I'm going to share will be useful to all of you. Let's see if I can advance. There we go. So the first new kit on the block was released this summer. It's from Dexcom. It's called the Stello. The intended population for this sensor are those with type 2 diabetes, not on insulin, and those patients with prediabetes. I do want to point out, patients have to acknowledge that they do not have any of the things listed in that exclusions for use in the lower right corner of this slide. So essentially, the Stello is pretty similar to the G7 in terms of type of data. It's continuous, it's the same size, placed on the arm, and compatible with both iPhones and Androids. However, there are some key differences. First and foremost, the glucose range is pretty narrow. So as you can see, 70 to 250, so much different than our prescription CGMs. Duration is a little bit longer than we see with the G7. So this sensor is going to last 15 days. So now patients will only need 2 sensors per month. However, the biggest and most important difference is that these sensors do not have any alarms. And this is why it is so important that patients that are on insulin or have a history of hypoglycemia do not use these sensors. So unlike the prescription counterparts, these are only available online. The cost here is listed for the 2 sensors, and you can note that the subscription that the patient can sign up for will save them 10%. And these sensors are eligible for health savings accounts and refunds. So switching to another product, Abbott, their current over-the-counter product was released in early September, but the first and biggest difference here between this Abbott Lingo and the Dexcom Stello that I just mentioned is the intended population. The Lingo is meant to only be used by patients for health and wellness, so not patients that have diabetes, nor patients on insulin. And so patients, once again, to get this sensor, have to acknowledge that medical action will not be taken based on the provided data, as seen in the lower right-hand corner of this slide. So if we were going to compare the Abbott Lingo to other Abbott products, I would say it's a hybrid of the Libre 2 and Libre 3. It's similar in size to the Libre 2, so larger, but it does have continuous data like we see with the Libre 3. Again, very similar differences to this that I talked about with the Stello, but I do want to first point out, while the glucose range is pretty narrow here, much actually more narrow than the Stello, so 55 to 200, but unlike Stello, it is only compatible with iPhones. Again, like Stello, there are no alarms. So again, this is why you shouldn't be using this sensor or recommending it to patients that have diabetes or at risk for hypoglycemia. So similar to Stello, also only available online. Patients can use their health savings account. The cost is lower than Stello, and there is an option to just try one sensor for the $49. But again, this is meant for health and wellness. So you might wonder, what's Abbott doing? So while at the same time when the Lingo was approved by the FDA, they also approved the Libre Rio, but unfortunately it's not out yet. We keep hearing that it's supposed to be coming out soon by the end of 2024, so the clock is ticking. But this sensor will be a true head-to-head competitor with the Stello. And so this is called the Libre Rio, just like the Stello, intended for patients with type 2 diabetes not on insulin. But I do want to point out here that I think this is going to be the biggest difference between the Stello and the Rio when we see it, is a wider glucose range. So keep in mind, when I was talking about Stello, I said 70 to 250. With the Rio, it goes up to 400 and all the way down to 40. We have several new tools per the request of you all. So we have 7-day meal plans for our Hispanic patients, along with meal plans for various vegetarian eating patterns. We co-developed a patient guide for bariatric surgery with quick facts, comparison guides of surgeries, and stats related to diabetes remission. And based on the idea of one of our practices, we have a low carb resource menu keychain and 2 posters that are listed here. And so you'll be receiving an email at some point here in the upcoming weeks if your practice is interested in ordering some of these items. Also, if you haven't seen already, please check our website for updates to the tools listed here. All right, so now we're going to switch over to medication updates. So one of these updated tools that I wanted to call out is our incretin mimetic shortage guide. So as you see on this slide, you might recognize the table from the original guide. However, this now only has equivalent therapeutic doses. So I removed the sensitizing doses from the chart, given that you should be directly switching from one therapeutic dose to another. I also added recommendations for the conversion to oral semaglutide if you happen to be switching a patient from higher doses of dulaglutide or semaglutide. Additionally, the new version contains these 4 new tables. And so we work closely with our content experts and available literature to create these tables for you to provide specific dose recommendations in instances where our patients have had a gap in therapy. So I do hope you find this helpful. Hot off the press, as of just 6 days ago, if you recall, just as far back as September, Medicaid of Michigan had preferred GLP preferences of Byetta, Victoza, and Trulicity. But as of November 1st, they've added Ozempic as another preferred agent. So this is certainly good news for our patients. So now another poll. I'm interested to know if you've prescribed any generic Victoza.
It looks like we got most responses in. We'll leave it open for just a few more seconds. All right, I'm going to go ahead and close the poll and show the results.
Thanks, Jackie. All right, so similar to the other meetings we've had, large majority have not prescribed generic Victoza. I have not either, but certainly wanted to talk about it quickly. Let me see if I can. All right, so I pulled this information about the ongoing incretin mimetic shortage directly from the FDA shortage page, which I wanted to point out you can check at any time. So it's fda.gov/drug shortages, which is one word. And so as you can see here, tirzepatide has resolved its shortages. Dulaglutide, while it's still listed in shortage, when you dive in a little deeper, it says all strengths are available. Liraglutide, similar to dulaglutide, still in shortage, but limited duration. But they do point out specifically that generic liraglutide is readily available. And so they state that Victoza is limited due to delays in shipping, while Saxenda is in shortage due to demand. And finally, semaglutide, still listed currently in shortage. However, all strengths of Ozempic are listed as available. I've seen this clinically. I should be knocking on wood, but I haven't seen too much shortages or my patients being unable to get Ozempic. As for Wegovy, they say all strengths are available except that initial dose of 0.25. So why I asked about liraglutide, I looked just to get an idea of pricing, and quite the range of pricing here. So anywhere from like $250 per month up to $850. So I imagine we're gonna still continue to see some prices drop, but unfortunately, I don't think many payers are picking this up. I do think Victoza going generic is why we saw the addition of Ozempic to Medicaid. So I want to spend a few minutes talking about this because this status of being resolved has caused some recent controversy I'm not sure you're aware of. So you might have heard that the FDA issued an update on this shortage, both as Mounjaro and Zepbound, and this was as of October 2nd, saying it was resolved. And they said this information was straight from Eli Lilly. But however, the FDA went on to add a caveat that disruptions could occur as the supply chain, so distributors and pharmacies need to adjust their ordering practices due to the drug now being available. So with this announcement from the FDA, this meant that compounding pharmacies could no longer compound the drug. So not so fast. So OFA, which represents FDA registered 503B outsourcing facilities that supply drug to certain compounding pharmacies, sued the FDA for the reasons listed here. So a few days after that status changed. But then 5 days later, the FDA changed its stance and agreed to reconsider their status of tirzepatide. This resulted in a letter being sent out as of October 17th, clarifying that compounding pharmacies can continue to compound tirzepatide during this reevaluation period. So just wanted to make you all aware of that, and we'll continue to watch as this, I'm sure, will once again change. There are some exciting improvements that I want to close upon with Medicare Part D coming up in 2025. So first and foremost, patients with Part D or Medicare Advantage that have their out-of-pocket drug benefits, they will all be capped at $2,000. So what does that mean? There is no more gap. So this we've been waiting for since the institution of Part D in 2006. So this is a pretty big deal. Only took nearly 20 years. Enrollees can opt in to the prescription payment plan so that $2,000 max is spread out over the year. Open enrollment is open now. So if patients are interested in this, they can actually call and get enrolled now for the start of January. But I do want to reiterate, though, that that donut is gone. So hopefully this is going to help out our seniors in terms of drug affordability. And I'm going to come back to the payment plan because I think we're going to want to be careful if our patients ask us about this on which patients might benefit the most from this. So as I mentioned, patients can opt in either in the beginning of the year, mid-year, they can opt out whenever, but a couple of key important points here. The payment plan does not save them any money. So we're going to go through some examples where this will be crystal clear, hopefully by my visual examples. The other thing is that premiums are not included on this. So if a patient has premiums, those are paid separately. And this is what I haven't quite wrapped my brain around of how this is going to work. When a patient goes to the pharmacy to get their meds, they're not going to pay the pharmacy. They're going to walk away with their meds, and the government's going to send them a bill. This has lots of little alarms going off in my head. How will patients know what their drug costs are? If you read the documentation from Medicare, they said call your prescription plan or ask your pharmacist. I know as a pharmacist, I'm not able to answer that, and I don't know how my colleagues are in the community either. I tried this recently with one of my patients to have them call their insurance plan, and they were provided the wrong information. So we'll see how this goes. But as mentioned, I do want to go through a few examples, but first, just to give you an idea, the first month, if they join in January, is calculated differently than any other month. So they're going to take that cap of $2,000 and divide it by the 12 months. So that first payment is $166 and some change. Should their monthly payment be less than that, that is all they will pay that first month. Then the remaining months, they're going to take a sum of whatever remaining balance is from that first month and add it on to the monthly charges for their drugs each month. So again, I didn't really understand this until I started to do all this to try to make it make sense. So this is an example if a patient had out-of-pocket drug costs of $500. So as you can see, nicely spread out throughout the year, they never pay more than $200, and that's great. Alternatively, I do want to point out, if a patient didn't elect this payment plan and they have $500 laying around each month, they could pay $500 for those first 4 months. They would meet that $2,000 cap, and then they're done paying for meds. So they would continue to get their meds, but at no charge. So as a reminder, though, as you can see in both columns, no cost savings. It's just a matter of how it's spread out over the year. So in this case, $500 out of pocket, this might be a great option for patients on a fixed income. So alternatively, if we say moderate cost, so $350, as you can see, again, spread out nicely over the 12 months, never getting close to the $350. And so they're able to, for half the year, really budget for no more than $200. Alternatively, they could pay for 6 months and then not have to pay any more after that. So this is the example of where I think we need to be mindful. So if you have a patient with $175 out of pocket, as you can see in those last few months of the year, that additive cost continues to mount. And so it means they're paying twice as much as they would in those last 2 months of the year. So I think it's important. I ran these numbers with lots of different examples. I'm going to keep in my brain, if a patient's drug costs are $225 or below $250, they're probably going to just want to pay for their meds, that this option won't be the best. But if they're over $250, it could lower it if they want to spread it out for the year. All right, so just as a reminder, unfortunately, we all know, sadly, in January, our patients that we're treating for obesity will no longer have coverage from Blue Cross Blue Shield of Michigan for our incretin mimetics. So unfortunately, I think we're going to all have to brace for this in the new year. But to wrap up on a high note, our team is very proud to report our recent publication of our collaborative and the development of our collaborative in Biomed Central Health Services Research Journal. So thank you all. And with that, I'm going to turn it over to Dr. Gavison.
And while you do that, Heidi, there's no more donut hole.
Yes, no more. It's gone.
No more donut hole.
Yeah, yeah.
Can everyone hear me?
Yes.
Yes, I get a thumbs up. Hi, everyone.
Jonathan, I feel like your sound is a little muted. Can you see if you can increase the volume a little bit?
Yes. How about now?
A little better.
And if I have any issues, I'll speak up. Let me know if there's any issues. Hello, everyone. I'm Jonathan. I'm going to be talking to you about something that's new for us. It's about our performance measure. And our performance measure is going to be A1C control. So what is a performance measure? Performance measures are tools used to assess the quality of care provided in healthcare. They allow us to track specific outcomes, processes to ensure that we are meeting standards that improve patient health and safety. They're also a measure to help us get paid for our work. So this is the first year that MCT2D is introducing a performance measure. In previous years, we focused only on participation-based measures, like attending the regional meetings, submitting surveys, working on process-related measures. But as we mature as a collaborative, we're finally ready to use our data to improve as a group. So this year, again, we're going to focus on glycemic control as measured by A1C. So what are our performance measures? For commercial patients, our goal is 70% of our patients with documented type 2 diabetes with an A1C less than 8%. For Medicare patients, our goal is 87% with an A1C less than 9%. Why did we choose these numbers? We wanted to align as closely as possible to the HEDIS metric for uncontrolled diabetes. HEDIS is an industry standard tool that allows for comparison in performance between different healthcare plans. The percentages listed above represent the HEDIS 90th percentile rates. HEDIS already defines excellent performance, and if you're already at the 90th percentile or doing better than the 90th percentile, that's great. You don't need to do any better, you just need to maintain that 90%. The first thing we want to say is that the vast majority of the collaborative is already at or above these rates, with minor exceptions. We wanted to launch our initial performance measure with a very achievable goal. And this is important since it's our first year moving from measuring just participation to also measuring performance. And we're still learning how to use our data. And so this is going to help us use that data. So the true goal of this performance measure is to make sure that your PO is comfortable using the data to improve. And in future years, we may select more challenging measures or multiple measures that POs can choose from. We will use this year as an opportunity to learn how to improve together so that we can use our QI skills, our developing QI skills, to accomplish new goals. So which patients of ours are eligible, are the eligible population? All Blue Cross Blue Shield patients with an A1C measured between June 1st, 2023 and May 31st, 2024 that have a documented type 2 diabetes diagnosis. Why are we starting with people who had a measured A1C? That way we know that your PO is sending data about the patient and that you are actively providing care for this patient. Your denominator will never increase. So if you have a new patient seen by your practice for the first time in November of this year, they will not be added to your denominator. That way your practice won't be held responsible for a patient who sees you for the first time with an uncontrolled A1C without you having adequate time to manage their diabetes and get their A1C under control. We calculated the baseline for this measure for all patients with an A1C measured in a 1-year period ending June 1st, 2024. The intervention period refers to when we are expecting you to actively be working on your performance measures. Your opportunity to improve goes from June to the end of April 2025. So let's take an example. There we go. We have a patient who was included in the denominator. They had an A1C on January 31st, 2024. They had another A1C taken on July 12th, 2024. A1Cs taken from June 1st, 2024 to August 31st, 2024, prior to the start of the VBR year can count towards performance. In this example, if no other A1Cs are taken before the end of the performance year on April 30th, 2025, the A1C from July 12th will be what is counted. However, if that same patient had an additional A1C taken on March 15th, 2025, that new A1C would be counted instead. And in this case, that A1C went below that 8% threshold, and now they are meeting our standards. Our design team really goes out of the way to make sure that the data you receive is easy to understand. So there are 2 ways that data is going to be available to you. First, we send emailed reports to your POs. Each PO received baseline report on September 6th. Your PO should have shared your baseline data with you, which includes the complete patient list that makes up your denominator. Your PO will receive and distribute information from MCT2D quarterly with reports to update you on your performance statistics. Second, the updated patient dashboard will track the performance measure rates beginning in December. Currently, the entire patient population is displayed in the A1C calculation, but in December, there will be the option to narrow it only to include the patients in your denominator. You will receive quarterly reports in November, February, May, and the final one will be in July 2025. So some of the nuanced parts. So if your practice has more than 100 patients that meet that requirement, your practice will be measured independently, meaning that you're only responsible for the rates within your own practice. And if your practice meets those rates, you are meeting the performance measure. For the practices that have less than 100 patients in their denominator, their practice will be aggregated with all other practices in the PO with less than 100 patients. This is in order to give you enough chance to improve, as we didn't feel that it was fair for practices with a small number of patients to be measured separately. If you only have 20 patients in your total count of people with diabetes who can be included, one patient can shift your percentages dramatically. You're still going to have the opportunity to earn value-based reimbursements for participating in our learning community. So 3% of the VBR are going to come from participation metrics, and 2% of the VBR will be tied to performance measures. If you already meet or exceed the performance level for A1C at the beginning of the VBR year, the goal is to maintain that excellent performance. We're also going to be responsible for reviewing charts of 5 patients per practice with an uncontrolled A1C and report key drivers to their poor control. This will be completed through the REDCap form that I think many of you are familiar with and will be available starting this month. Why are we doing this? This can help the collaborative learn about our patients and practices and find additional opportunities to improve diabetes care in future years. We believe strongly that people with poorly controlled A1C represent health disparities that can be due to social determinants, comorbid mental health conditions, or other crucial, important systems issues. And we hope that this qualitative approach to gathering feedback from all of you on our patients will help us learn more about meeting their needs. These are examples of the chart review questions. So objective data like the most recent A1C and date, current medications and doses, but also subjective data on your part, identifying primary challenges identified, like is it the coverage of medications or cost for medications or patient motivation? And then what is your practice's next step to support that patient? Okay, so hopefully you understand the terms of the performance measure and how it will be calculated. If you have any additional questions, feel free to put them in the chat and either myself or one of my colleagues will help answer them. Now we want to transition to talking about how your practice can address common drivers of uncontrolled A1C and better understand what these primary and secondary drivers are. So as part of the regional meeting registration, we asked you if you could implement only one quality improvement initiative into your practice to help patients with uncontrolled A1C, what would it be and why? Those suggestions for improvement were incredibly valuable to us. While we understand so many factors impact uncontrolled A1C, we wanted to have you focus in on what you see as the key driver so that we could create a diagram of what this looks like across the MCT2D collaborative and identify opportunities for intervention. We grouped your ideas and suggestions together into something called a driver diagram. This is a visual tool to share what the collaborative thinks is driving poor A1C control, as well as what we might change to improve A1C control. We have 2 kinds of drivers. The primary driver are the most important influencers on the aim. There are usually about 2 to 5 primary drivers for any given problem. The secondary drivers are influencers on the primary drivers. There can be many, and these allow us opportunities to generate change ideas to implement quality improvement in future PDSA cycles. When you think about these drivers, the next step is thinking about how to test them and ways to measure that change. Our aim is to either maintain or improve A1C control. We grouped your ideas that you sent into 4 primary drivers. Again, these are the most significant influencers of our problem. And we'll go through each individual primary driver and some of the ideas that you mentioned. So primary driver number 1, monitoring diabetes control. We took your comments, let me show you the comments. We took your comments and compiled them into groups of secondary drivers, which is labeled in this white writing on green. 1, using CGM for actionable data between visits. 2, outreach for labs prior to their visits. 3, on-site point-of-care A1C machines. And 4, scheduling visits for patients who don't come in. By far and away, the most common suggestions in your ideas had to do with how can we better utilize CGMs. And these comments were an answer to what one quality improvement would you implement? So the first comment here, CGM usage for every patient, because we have seen great results when the patient can follow diet choices and eating patterns and compare them with changes in their blood sugar levels. The second primary driver that we identified based on your comments is lifestyle change and education. So for this category, the secondary drivers include regular diabetes education, personalized education to patient needs, focused carbohydrate reduction counseling, access to a dietitian, and group support. And here is where the team is so important. So physicians, our APPs, our dietitians, pharmacists, our care managers, our nurses, our medical assistants, our clerical staff, the patients and their family, even community organizers can give us a big picture of all of the elements contributing to those primary drivers. And your comments here highlighted the value of those participants. The third primary driver is medication management. These suggestions focus on assisting with medication coverage, adherence, clinical inertia, or escalating a medication regimen when needed. The secondary drivers included better insurance coverage, staff to support with coverage and affordability issues, monitoring adherence to treatment plans, and knowing when to escalate insulin. And so here are some of your comments. Freshest on my mind would be assistance with insurance coverage for GLP-1 and SGLT2 medications. Recently, I had a patient with an uncontrolled A1C on large amounts of insulin who had coverage for GLP-1 or SGLT2 with Medicare Part D, but was not able to afford and was not willing to file an appeal with me. And I've seen that too before. So finally, our fourth primary driver, patient follow-up and support. So these secondary drivers include access to care managers, treatment adherence, and education with action plans. And here are your comments. So an example of one comment is improving education. We're in a rural area and many people do not want to drive to Saginaw where the closest dietitian or diabetic educator is located. So here is everything all together. Your primary drivers and ideas for change. Your primary drivers are in the middle and the ideas for change branch out from that. We're now going to launch a few poll questions to see how you plan to maintain or improve performance. And you can use some of these ideas here. Can you open the poll for me? There we go. So the two questions are, the first question is, which of these primary drivers is your practice's biggest challenge? And the second question is, which of these primary drivers do you plan to address within your practice to meet or maintain performance measure target rates? We're at 20. I'll give you guys another 15 seconds. So as you can see in the results, so which of the primary drivers is your biggest challenge? It seems fairly balanced, but lifestyle change education seems to be the biggest challenge. And then which of these drivers you plan to address? Again, very similar numbers with lifestyle change education being the predominant one. So our goal is to help each other succeed. We want to improve or maintain our patients' A1C. You will have the support for this quality initiative from us, from your POs, who will be sending you quarterly data updates, including patient information from MCT2D. And then we'll help, and they'll help be a liaison for your questions and requests for support. Any questions?
Thank you so much, Dr. Gavison. I'm sure there will be questions in the chat. I am going to take over screen share at this time, but we're going to take a very brief break. So we're going to give you 3 minutes. We're going to convene back together at 7:13. If you need to stretch your legs, take a drink, turn the camera off, please do so now. Our team will continue to be here and answer any questions in the chat while you wait. I'm going to start bringing us back together and just reorient you to our timeline. We are staying pretty well on time. This will not take, I promise we will not keep you past 8 o'clock. I'm going to introduce myself because I wasn't here at the beginning. My name is Lauren Oshman, and I am the program director of MCT2D. I'm a family physician and excited to be here with you tonight. Had to be on call until 6 at the hospital, so I appreciate the team starting this off for me. And so we're going to have an opportunity here. I'm so excited to have some special guest speakers that I'm going to introduce for you. And I am so thrilled to introduce Shelly Smith, who has been one of our patient advisory boards really almost since the beginning of our collaborative. I remember hearing Shelly's testimonials of her diabetes care, and we just really so value her work. And so I'm going to let you introduce yourself, Shelly, and come off mute, and we are excited to hear your story.
Thank you. My name is Shelly Smith, and I am here to tell you about my experience with prediabetes. As you can see, I'm married, have 3 children and grandchildren, and all of the things that I enjoy to do on my slide here. I joined the board hoping to share my experiences that I have had, might make a difference to people who are dealing with things, as well as learn from other people on the board. And I have learned so many good things on the board. It's been a very enjoyable process. And we've done so many different things, developing teaching materials. It's just been a really positive experience for me. I enjoyed when we have worked on teaching materials like low carb shopping lists and worksheets for patients to learn about their health insurance. And I hope to continue on and educate people more practically from our perspective as a patient. My journey with diabetes, pre-diabetes, started when I was in nursing school. It's been quite a while now, probably 15 years. And at the same time, I was diagnosed with hypertension. So the whole process was mixed because it was a very busy time for me, and my doctor put me on a blood pressure med, but he said my sugars were in the pre-diabetes range. And then he said that because of the stress I was under being in nursing school, he didn't think that I would need to be on the blood pressure med after I graduated. So I just assumed at that point that he meant the same thing about the pre-diabetes diagnosis. So, and after that, we really never discussed it again. The whole pre-diabetes thing, my sugars were stable. So then I graduated and I was working on a med surge floor, and we did hemodialysis on that floor, and I ended up needing a surgery, and I developed acute renal failure at that time. And I got a call from that doctor. He was my primary care physician, and he told me I had chronic renal failure. Well, I was a hemodialysis nurse. I mean, we had a nurse that did it, but I was on that floor and I was devastated and freaked out. So I was fortunate to be able to see a nephrologist really quickly. And she told me that that is a diagnosis that you just don't make it off of labs. It's, you have to have biopsies and stuff. And I ended up with acute renal failure, which wasn't great, but it resolved itself. So I called that doctor, my doctor, and said, I told him that what the diagnosis was, and he said he said that I wasn't taking care of my health and he dumped me as a patient. So that was pretty humiliating and stressful. So in the meantime, my sugars still were okay, and I hadn't heard anything more about prediabetes. And then I found another doctor, and then I developed asthma, and then I was being hospitalized several times, and I was put on steroids. So then my blood sugars were coming back up again. And then I have a friend who was my PA when I was in the hospital, and they looked at my labs, and my doctor told me that I was diabetic. And my friend said, don't you worry about that. You're not diabetic. You have high blood sugar because you're on prednisone all the time. So I told my doctor about that, and he was mad at me. So, but the problem was, it was me. I was not happy. I was in denial, and I didn't want to be diabetic. So the point that I want to make here is the pre-diabetic diagnosis was just like a one-time event. And as a nurse now, I know that it should be a process. There should be information. It should be, yeah, a process where you tell somebody and then you have information for them, lifestyle change recommendations, education, and follow-up in a gentle manner so people can get used to the fact that this is true, pre-diabetes. It's hard because you don't hear about it very much. I don't know how much it is now, but back then, even though I was in nursing school, I really didn't know that much about it. So I just have to say that it would have been a lot better if it would have been more of a process. And that's my story. Thank you.
Shelley, I just really appreciate especially the vulnerability of sharing what are some not so positive ways that you were treated. And we're all clinicians in this room, almost all of us, and I just feel like I have to say out loud, no one deserves to be treated that way, and I'm really sorry. I just really value you being here and spending your time with us, and I think part of what is so important to us at MCT2D is putting the voice of you as the patient, right, as a healthcare provider, but also a patient first. And one of the beautiful things about having these regional meetings is it gave us an opportunity to do that. So my hope is that even with our in-person regional meetings, we can find ways to bring our patients into those events and mingle some more, but I'm just so thrilled to have you here. Thank you. I'm going to share just some brief information about prediabetes. We asked you as a collaborative, what should we be working on to really get to our long-term goal of creating a world where diabetes is no longer a progressive disease? And you told us that working on prediabetes was important to you. And so this is really the first steps of us figuring out what that looks like as a collaborative and how we improve. So I wanted to share some basic definitions, and then I'll transition us to our next speaker, which is that we define diabetes in a couple of different ways. You all know that these common definitions are an A1C over 6.5 and fasting plasma glucose over 126. Typically, we want to measure this a couple of times or on 2 prior occasions prior to applying that diagnosis. And in the US, prediabetes can be defined as between 5.7 and 6.4, but interestingly, in Europe and Canada, the criterion at the low end is 6.0. So they have a little bit more of a stingy definition of prediabetes. And thinking about how it makes you feel when you get that diagnosis, I think it's interesting that it's slightly different in different areas. And so I think the important thing that I talk about with most of my patients is that this cutoff between type 2 diabetes and prediabetes is somewhat arbitrary, but really was built off that increased risk of complications, macrovascular complications like heart attack and stroke. But we know that those problems can start even 5 years before the diagnosis of type 2 diabetes. The risk of microvascular complications like neuropathy can start at that time of type 2 diagnosis. So simply put, the longer you have elevated blood sugar, the higher your risk might be of complications. And, you know, I think at certain points in my career, I thought, like, why would we talk about prediabetes? You know, what are the available treatments for this? And I think the answer is that we can really engage not only in reducing the progression to type 2 diabetes, but giving people lifestyle change skills that can help them with quality of life. So the USPSTF kind of builds preventive guidelines for average risk patients, and these guidelines are pretty simple. Anybody over the age of 35 and under the age of 70 or 35 to 70 who has overweight or obesity should be screened. And so for me, that's something I feel like I can stick to in my practice. It's pretty easy to remember and apply on a population basis. But I wanted to show you the American Diabetes Screening Guidelines for prediabetes. And the ADA puts out this manual of standards of care every year. It's hundreds of pages long. Heidi and I and our team leafed through it, and Jonathan to give you those updates. But if you can't read this, I'm trying to make a point, which is that the ADA guidelines are not simple. And so I feel like you got the easy way and the hard way, and it's pretty challenging to think about how I would implement this in practice. And so the ADA partnered with the American Medical Association and has a tool called the Prediabetes Risk Test. This is used a lot in public health settings or in health departments or health fairs so that people understand their risk and whether they need to be screened. So we asked several of you, we had a survey at the end of the last VBR year and asked about 98 of our practices about how you're doing with prediabetes screening. And 60% of you said that you screen annually, 31% say it might depend, and 9% are screened as needed. And what it depends on is oftentimes the weight status of the patient, insurance coverage, or different physicians or providers manage this differently. And then we asked you about your referral to treatment. What do you do when you diagnose someone with prediabetes? And the diabetes prevention program, which we'll hear more about in a minute, 35% of you currently refer, 61% of you have never referred, 4% used to but stopped. And your beliefs about how it works, 53% felt like it was really hard for your patients to complete, 29% said that not more than half completed, and 18% said that it works for most of your patients. In terms of effectiveness, again, some of you find it very effective and some of you not so much at all. And so with that, I'm so excited and really, again, grateful that Caitlin McAvilly Rosenbach from the National Kidney Foundation of Michigan was able to join us this evening. And we thought it would be such a valuable opportunity to bring NKFM to you to explain a little bit more about the diabetes prevention program and specifically what they offer.
Dr. Ashman, I'm going to share my screen.
Take it away.
Oh, sorry
We
about
got you.
that.
I see your slides. I saw your slides.
I'll try that again. I am traveling, and so I don't have my typical setup, which threw me off unexpectedly. Sorry about that.
I see them again.
Okay, there we go. Great. Thank you so much, Dr. Ashman. And I really am honored to be here speaking with you today about the NKFM as well as the Diabetes Prevention Program. I'll give you a very brief overview of the National Kidney Foundation of Michigan and the Diabetes Prevention Program, and then tell you more about how we implement the program and how we could work with you to serve your patients and be that treatment for prediabetes. The National Kidney Foundation of Michigan is working to prevent chronic kidney disease and improve the quality of life for those living with it here in Michigan. And we work in communities statewide with strong partners to affect change through education, programming, and support services. We do this work in three main areas: community health, disease management and prevention, and kidney health initiatives. Within community health, we focus on community outreach and engagement to build prevention across the lifespan. This includes early childhood programs around fruit and vegetable consumption, family programs around cooking and grocery store tours, as well as programs in health fairs and outreach. The Disease Management and Prevention Division serves adults and families with and at risk of developing CKD and ranges from falls prevention and adult physical activity programs to health coaching, including the Diabetes Prevention Program. We also obviously do some work in kidney disease management, including kidney healthcare initiatives, where we're working to improve screening and early diagnosis of CKD in Michigan through engagement and technical assistance with health systems and health plans, as well as services for people with chronic kidney disease, which include an emergency fund and patient support group as well. As far as the Diabetes Prevention Program, Dr. Ashman did a great job setting the stage for prediabetes, but I think I want to talk a little bit about the scope. It's estimated that 96 million Americans, or 1 in 3, have prediabetes, and more than 8 in 10 of them do not know it. We know that there are some common risk factors that were discussed and are in that ADA risk test, including an age of 45 or older, a elevated BMI, family history of a parent or sibling with type 2 diabetes, as well as race and ethnicity. As far as the diabetes prevention program, it's a year-long program proven to reduce a person's risk of developing type 2 diabetes. Each cohort of 10 to 20 people meet for 1 year, weekly for 16 weeks, and monthly for the remainder of the year for a total of 26 sessions. Participants track their food intake and make action plans with the goal of losing 5% of their body weight and working up to 150 minutes of physical activity per week. The session content is facilitated by a trained lifestyle coach and begins with setting the foundation for lifestyle change around physical activity and healthy eating, and then transitions into the social and behavioral influences of our lifestyle choices. Session topics include getting active, eating well, managing stress, sleep, and more. The program focuses on small steps and simple changes that lead to routines and then habit formation around the lifestyle changes that can be impactful for the individual participant. And so NKFM lifestyle coaches culturally tailor the DPP to meet the needs of the individual participant while keeping the program general enough to engage those cohorts of 10 to 15 people. The Diabetes Prevention Program research study was funded by the NIH and CDC and included over 3,000 participants from diverse racial and ethnic backgrounds as well as ages. The participants were randomly assigned into 3 groups: the Lifestyle Change or Diabetes Prevention Program group, which helped participants achieve and maintain that 5% weight loss and 150 minutes of physical activity per week, also assigned to a metformin group and a placebo group. The medication group did reduce their incidence of type 2 diabetes by 31%, while the lifestyle change group resulted in a 58% lower incidence of type 2 diabetes. And this was even greater for those over age 60 who reduced their incidence of type 2 diabetes by 71%. 15 years later, those within the lifestyle change group still had a 27% lower incidence. The diabetes prevention program works and can continue to work as a participant goes through their life as well. As far as the NKFM and DPP, we've been delivering the program since 2012 and been fully recognized since 2014 and have served over 5,000 patients. Last year, we registered more than 880 people across 60 cohorts with 60 active lifestyle coaches. We currently offer the program in English and Spanish, and I do want to note that our Spanish language implementation is not simply a translation. It is truly a culturally tailored and developed approach to reach the Hispanic Latino community in a way that is relevant to them and their individual cultures. The DPP program is supported by a robust data framework that supports program administration, assessment, and sustainability, and can also provide reporting. And we have a robust billing and claims system and have been submitting commercial claims since 2015, and our Medicare and Medicaid DPP suppliers. We currently offer the program both in distance learning and in person. Distance learning is Zoom, just the way we're meeting today, and the majority of our programs are offered in distance learning. Here you see the path a potential participant takes to become a DPP participant. Well, a participant may find us in many different ways through a healthcare provider referral, phone call, or a health fair, filling out that risk test that Dr. Oshman shared. We respond to that initial inquiry with outreach from our referral management team. We learn more about their interest, answer questions, and register them for an information session. They attend an information session to learn more about the program, including both what they can expect from NKFM and our lifestyle coaches, but also what's expected from them, that they are expected to attend the session to report their weight and physical activity minutes, to track their food and action plan, and really understand that this is about not only attending the sessions, but doing the work between the sessions. Following the information sessions, the participant can choose to register for the program and engage in the year-long lifestyle change program. Throughout the process, both at beginning and then again throughout at 8 and 16 weeks, NKFM works with the participants to identify and address social influencers of health. We have resource navigators who work with a participant to ensure their health-related social needs are met so that they can fully engage in the program. So to speak a little bit to the concerns that Dr. Ashman shared around retention and completion, you can see here what our completion rates are at 4, 7, and 10 months. At 4 months, 90% of the participants are retained. At 7 months, 85%, and at 10 months, 76%. This is vastly exceeding the CDC expectations of 50, 40, and 30% respectively. And I truly believe this is because the NKFM lifestyle coaches are directly addressing the needs of the participants within their groups and are really very skilled at doing this work. Of that same cohort evaluated, 61% of participants demonstrate a risk reduction for type 2 diabetes. So this is either achieving 5% weight loss or 4% weight loss plus 150 minutes of physical activity. And these are the current CDC standards for risk reduction. Well, we have that data. I do want to share a little bit about the individual participant experience and what they are saying about the program. So on the screen here, you can see some participant quotes. We collect feedback throughout the program. And what we see here is A1C reduction and weight loss as we would expect. But in that second bullet, you can see a participant talking about, even though they haven't met their weight loss goal yet, they are still seeing health-related changes in their metrics. So blood pressure is dropping and they have more energy. And then that third bullet talks about the benefits that social support can offer. They provide crucial moral support, and it helps to know that others face similar challenges. I think this speaks to some of what Shelley was saying around the gentle approach to lifestyle change, that information and education can be provided in a way that can really engage a participant and allow them to be successful. What does this mean to you? So the NKFM, there are many DPP providers in Michigan. The NKFM would love to work with you. Your health system or clinic may already be a provider, and we'd love to connect you with those if that would be helpful. And we would love to meet your needs if that would work for you as well. Typically, this could happen in 2 ways. You could refer eligible patients to our distance learning programs, or you could become a host site. One of the hallmarks of our referral systems is that we will not take a one-size-fits-all approach. Our referral management team would work closely with you as a referral agency to determine what the right referral mechanism is for your patient population or community. This could include point-of-care referrals through EHR direct address, could do some batch outreach through letters, identifying those who have prediabetes within your EMR, and we would be happy to make those outreach calls for you. So lots of different ways we could do this that would work for you and the patient population you serve. We do know that your input is really important. A batch outreach is probably not going to have the same effect that a point of care referral would have. Batch outreach is much lower, around 2%. Point of care is somewhere between 10 and 15. And depending on how engaged the provider is, we can see that up to 25%. So this is a conversion from referral to enrollment in the program. As you consider referrals, we encourage you to have a discussion with your patient about the opportunity for engaging in the DPP when you make that referral. Acknowledging the challenges of lifestyle change while offering the diabetes prevention program as a solution that will provide education and support to help them reduce the risk of type 2 diabetes. In this way, NKFM can act as an extension of your care team to help the participant achieve real results and lifestyle change. This is for your information. NKFM would take care of all of this. We work to ensure that cost is not a barrier for participants, and the program is currently offered at no cost. Medicare, Medicaid, and a small number of commercial health plans also cover the program, and we seek grants and scholarships to cover the cost for participants. If you are interested, we would love to work with you to ensure your patient needs are met. When you send a referral, our team would work with the patient one-on-one to ensure they are in the best class for them, including day, time, language, etc. We can also work with you to provide reports based on your practice needs to understand participant engagement and progress. And as I mentioned, be an extension of your care team and engaging them in the lifestyle change so you can see the results. In closing, I want to highlight that the NKFM has a vast amount of experience in implementing the diabetes prevention program successfully in diverse communities in Spanish and English, exceeding the CDC's expectations. The diabetes prevention program is central to our mission of chronic kidney disease prevention, and we are committed to delivering a stellar product meeting the needs of your patients or our participants. You can see my contact information on the screen, and I'll include it in the chat. The MCT2D team will also share it following the meeting. I would love to meet with you or email with you to discuss how we can prevent CKD and diabetes together. Thank you so much.
So much. I'm going to kind of move us back through so we can get to end on time. But Caitlin, if you can look at the chat, some of these questions about knowing who pays for it are things I think we're interested in developing as a collaborative and host site. So we'll have Caitlin drop her information and then share with you an email after our meeting, as well as starting to think about the next steps. I'm going to share my screen again and take us to the end of our evening. Great. Okay, we are now, I hope, looking at a picture of a brainstorming activity. Excellent. So what I'm sharing with you is a screen picture from our annual collaborative-wide meeting. And this is where physician organization representatives, some of you might have been there, participated in a brainstorming exercise to identify what are the barriers to improving diabetes prevention and what solutions might help. And so we wanted to take that activity forward and bring it back to you and really cross-map that with what you're experiencing in your practices. And so we came up with 4 big buckets of areas where the physician organization leadership thought we might be able to improve diabetes care. And those are screening and diagnosis, behavior change, treatment of prediabetes, and data tracking and population health. And so I'm going to share this with you in terms of all of the barriers and facilitators, and then we're going to do a poll because I really am interested in understanding what we can do as a collaborative to move all of us forward in this area. So in terms of challenges on prediabetes screening, there was some sense of not understanding exactly what constitutes prediabetes. Is it a diagnosis? Is it a risk score? What does that mean and how do we define it? What is the standard process? Having patients come in for visits just to look at this, time and knowledge from the physicians, APPs, and providers, patients completing labs, and then understanding who's at risk and who to screen. And some of the solutions that came up were looking at screening outside the clinic and community engagement, specific guidelines on what it is and how to screen for it, and then communicating. So as Shelley brought up, how do we communicate with patients about what it means that they have prediabetes? Coverage or incentives potentially for doing this, and then tools for DPP, and that's something that's been brought up in the chat already. What about treatment? You know, I think, again, we've really talked ad nauseum about provider awareness and education about DPP, and I think we'll continue working on that. Who covers it? Challenges with social determinants of health. Certainly, we all know that obesity is a risk factor for prediabetes and diabetes, and coverage for medications to treat that is difficult. Compliance, so engagement and motivation with patients who have that diagnosis, and then availability of resources. We don't always have that team in our office to help them. And solutions, hoping to do more advocacy with coverage of treatments for obesity and diabetes prevention, expanding CGM coverage, maybe some communication resources. Maybe we need to create some better resources to explain prediabetes to patients, and then guidelines. What is it supposed to look like to have that excellent education? Behavior change support, again, lack of resources, getting our patients motivated, having a supportive family. You know, in our clinic, we have some group classes for nutrition, and it say you really should bring your spouse if they're the person who is cooking your meals or helping with the shopping. Social determinants in education. And so thinking about, could we provide any type of local lists or connect practices with programs or external dietitians if you don't have one, classes, resources, and education, and then making DPP available. And then for data and population health, I think this is a big gap that I hope the collaborative might fill with time. Accuracy of data, and that maybe at the practice level, having a data directory of patients with prediabetes. There's no quality measure around this. And so it would be something that we would be defining on our own. What does good look like with managing prediabetes? Not having enough staff and information to work on population health, and what do community health workers look like in that space, and tracking. And so some folks had mentioned, you know, maybe we need to have guidelines about which codes to use for this, leveraging EMR tools to prompt behavior, and then providing data from all payers, which is something that we might be able to do eventually. And so then we asked those of you who participated in that end of year poll about what we can do to help support you. And, you know, the answers really centered around education and resources, resources for patients, I think educational sessions and supplies, I'm not sure if that's for clinical teams and patients or both, more information on the DPP, and then certainly coverage issues. And so with that, I want to try to use this time that we have together to get a good sense of where we should put our energy. Some of these things are easier to do than others. Building a dashboard for prediabetes is going to take a while if we decide to do that. But we're going to open a poll at this time. And I'm going to leave this slide up because it has the answers. And I'm going to ask you to select which of these items would be the highest priority for you. If you could only pick one thing that MCT2D could do to help support you in your practice. I know this is a long list and the poll options don't match exactly to where the sticky notes are on the slide. So I want to give you a little bit of time to read through this and select what you think is most important to you. All right, so we've got 39 respondents. I would love to see the last few. We're up to 47, maybe 3 more people to report out, and then we can close the poll and tell you what we see. All righty, I think we've had more than a minute. Let's go ahead and share the results. So hopefully you see these results shared for you, and just appreciating that as a collaborative, we're having 4 regional virtual meetings, and we're going to collect all this information and really decide where to put our time and energy. So 40% of you said having classes, handouts, webinars, or resources for patients was most important. List of a local program also got a lot of votes, as did education for physicians and patients. So we really appreciate that. All right, we did our poll, and so now we are ready for wrap up. We really do appreciate your engagement and attention with this action-packed meeting. We got through a lot in 2 hours. We do, as always, want to ask you before you leave, though, to help us plan our learning community events for the next year. So last year, you gave us all of your suggestions, and I'm going to show you a list of all of the wonderful things that we've taught and you've learned, and I really have appreciated the wonderful caliber of speaker and the variety of topics we've had. So we want to know what you want to talk about next. You can pick the same thing if you want us to go over a topic twice, but there may be new things. And so we are going to launch what I think is our last poll. And I'm just going to ask a free text answer. Just tell us what you want us to program in those monthly learning community events, and we will work on that for you. Yeah, I'm going to answer Dr. Haber's comment with a comment, which is, if you have a patient with prediabetes and you're giving them a medication, are they labeled by insurance officially as type 2 diabetes? This is where I find, sadly, because of the disparity in coverage for incretin mimetics and other diabetes medication, if I have successfully treated someone with prediabetes with metformin, then they don't get the diagnosis of prediabetes. Then sometimes it can be really challenging when they lose coverage. So if they've been treated with an incretin mimetic, but their insurance drops coverage. So I'm hoping we can advocate for those sorts of barriers to stop. I haven't found that officially gets them a diagnosis of type 2 diabetes if you're using the medication, and we use metformin for polycystic ovary syndrome and all kinds of things. So that's what makes it so challenging for us to build our data dashboard for MCT2D, because we have to sort out and make sure we're not including those PCOS patients in your population for type 2 diabetes. So we've got 30 of 52 participating. Continue to give us those suggestions for what you'd like to see covered. And then we will move on to the evaluation portion of the evening. This is where I'm always so grateful as well to the excellent sound quality on Zoom, because none of you can hear my chihuahua making noise in the background. All right, we've got a 80% using metformin, Dr. Haber, and quality measures. Yep, I agree. And we've had some conversations with some of the teams responsible for HEDIS and NCQA measurements. And I think we've done some advocacy in that space as well about those data definitions. Thank you for mentioning that. I've never seen anybody be penalized for lifestyle change. So another wonderful reason to participate in DPP. So we've got 45 of you responding. We've had this open for about 2 minutes. I'm going to go ahead and end the poll, and certainly you can let us know through other means what you'd like to know about. And we're going to move on to our very final slide. And so Jackie, I am going to ask you, should we show the CME slide again or just send that out by email?
We are going to send it out via email in the handout. Anyone who registered for the meeting in advance will have already received it. And we also put the text option in chat at the beginning of the meeting. I'll do it again right now, just for anyone who joined later, but we will make sure that you get it.
And then anything else you want to cover before we say goodnight?
Nope, I think we're good. If you can just explain the evaluation, it's up. Well, I can go over it. The last
Please
thing.
do.
Yes. The last thing for your attendance, when you exit out of the Zoom meeting in a new browser, there will pop up an evaluation about the meeting. That's the last piece in order for you to earn credit for attendance tonight. So we want to hear about your experience with the virtual meetings and how we can make them better in the future.
So with that, you are welcome to say goodnight. We really appreciate your attendance and engagement. We're really pleased to have been able to offer these virtually, and we truly do want your feedback to make the best use of this time and sharing as a community. But we will see you all in person in the spring, and make sure you have those dates to save soon. Take care.